Hi everybody, my name is Carissa Shaw. I am doing my final project on the adolescent suicide rates continuing to climb in the US. With this, I will be asking Bill and Melinda Gates for funding for my interventions. So, like just mentioned, the issue at hand is that suicide rates are increasing in the United States, especially in those of women and adolescents, mainly due to untreated mental health issues and significant family history. Most of the time, you can see that suicide rates are high because of family history and whether they have other family members with other significant mental health issues. These issues can include alcohol and substance abuse, feeling of hopelessness, physical illness, access to lethal methods, maltreatment, aggressiveness and impulsivity, and then sometimes even cultural and religious beliefs, as well as isolation and suicide epidemics. Most of the time, these are the types of people who are unwilling to seek help because they just feel like they're hopeless and nothing will work for them. Another huge part of the reason why young adolescent girls are increasing in suicide rates is because of social media and cyberbullying. Um, these issues have become more prominent in more recent years because of the development of more social apps and websites and um, young kids getting cell phones at younger and younger ages. I remember getting my first cell phone at the age of 16, and now I see kids who have cell phones at the ages of 8, 9, and 10, which is just adding to the issue of cyberbullying and social media issues, um, which leads to these kids needing antidepressants or anti-anxiolytics, which have been increasing. And you really don't think that these types of kids should need to have these medications at such a young age, but sometimes it's really the only thing that will help them feel better about their situation. So here I have the socio-ecological model in each level as to what will help and what hinders the issue of increasing suicidal rates. As you can see, I started at the individual level at the top and made my way down to the policy level. So we can just go through some of the what helps and what hinders this situation. So, for example, and the individual level. Social skills are really can what help an individual um, decrease this rate as they can ask for help when they know they're struggling. And it's also known as improving connectedness. But at the same time, age and gender is what hinders this problem because the younger the child is, the more chance they have at an increasing rate of suicide because of some of the things they go through. And it's shown that these actions are starting at the age of puberty, as young as the age of puberty in girls. Another example would be the organizational level. So obviously, therapy and counseling is one of the biggest things that people use to help cope with how they're feeling and look at different strategies as to how they can handle life when these obstacles are thrown at them. Two types of different therapies that I find to be very successful are cognitive behavioral therapy, or CBT, as well as dialectical behavioral therapy, also known as DBT, in which patients um, basically relive different situations and have to figure out a way to cope and handle them in a more positive way. One problem with this is that some health insurances aren't able to cover these types of therapies. So if it's really needed, these individuals will have to pay out of pocket. Either that or they just won't be able to have it and they won't know what types of ways things can help them. Lastly, we can talk about the policy level. Something that helps a lot is nonprofit organizations for suicide awareness, funding research to improve these interventions, like training clinicians in suicide prevention, and advocating for policy that will help these save these lives is really important in decreasing the suicidal rates in young girls. Something that hinders this is that not all 50 states have these regulations. So it's concerning because it won't be able to prevent and respond to these suicidal behaviors. So some interventions that I have come up with, like mentioned before, cognitive behavioral therapy, CBT, as well as dialectical behavioral therapy, DBT. Um, like mentioned before, they use emotion regulation strategies as well as index cue cards, mindfulness, opposite action, and problem solving strategies. Something else that's really helpful is CAMS, which is Collaborative Assessment and Management of Suicidality. In this, outpatient care is the goal, which is designed to strengthen the therapeutic alliance between the patient and the clinician. It's best understood as a therapeutic framework that emphasizes collaborative assessment and treatment between the two individuals. Um, Another intervention, which is really helpful, is called non-demand caring contacts. These people are someone who aren't directly related to the treatment, so it's not a clinician, it's not a therapist, it's not someone who has been a part of their process to be treated, but it could be someone else who works in the building. And basically, these people are just trying to engage with the individual and keep them in contact with their provider, and most of the time, this is done through postcards or letters, telephone calls to follow up, emails, and text messages, because most of the time, kids these age are really into social stuff. So, text messaging, email, online stuff would be really helpful as opposed to a letter or a postcard, but those are also some different options. So, evaluation, to know to see if the interventions have worked, basically an increased knowledge on how to cope with feelings and suicidal ideation through CBT and DBT is one way to know if the intervention worked. In regards to um, non non-demand caring contacts, the increased rates to follow up between the at-risk adolescent and the clinician, improve the individual's wants to engage with the necessary staff members. And then for CAMS, it's increase the motivation to live life to the fullest of those adolescent females who are struggling with bettering themselves. And ways to measure these are just through comparing these rates with past years, um, to see if they have gone down, and then especially with non-demand caring contacts, if the individual has interest in staying in contact, that would prove that this intervention was successful, and if they have no interest, it would be unsuccessful for them. Some of the challenges and barriers, individuals not wanting to take part, not taking the process seriously, or even not having the sufficient staff. Um, for the first two, to make it better, basically just having a better explanation of how it will help their future in layman's terms so they actually understand. And then in regards to not having sufficient staff, you can either pay them for their time to increase their interest or even just turn to voluntarily having them as the staff for help. So here is my model, and it basically just shows the inputs, the activities, the outputs, outcomes, and impact. So the inputs are the funding, the staff, meeting space, postal service, telephone calls, and the activities are the interventions. The outcomes are the evaluation, and the overall impact of these is to decrease suicide rates among adolescent females in the United States. And here's my bibliography. So with that, Bill and Melinda Gates, I really hope that you will help me with my funding. That way we can decrease the suicide rates in females in the United States. Thank you.